Welcome to the Real Integrative Medicine podcast. I'm Dr. Jordan Robertson, and I'm here to bring you the tools, insights, and strategies to take your health to the next level while using evidence-based integrative medicine. What's real? This is what we want to explore together. Research is ever-changing and not easy to interpret. We're bringing you the best that integrative medicine has to offer while sticking to the facts. Our mission is to elevate the practice of integrative medicine for clinicians and patients alike. Preventative solutions, nutrition, exercise, and sometimes supplements have a seat at the table in medicine, but only if we uncover real science-backed solutions. It's time to uncover what works and challenge what doesn't. Let's unlock your full health potential with an integrated approach. Ready to learn what's real? Let's dive in. Welcome to another episode of Real Integrative Medicine. I'm Jordan Robertson. I am a naturopathic doctor and the host of this show. I am so thrilled to have Dr. Mathew Leonardi here with us today. This is the second time that Mathew has been on the podcast. Welcome, Mathew. Thanks so much for joining me again today.
Hi again, Jordan. It's great to see you after quite a few years. Much has happened. As we were saying in the lead up, we've each lived 1,000 years or 1,000 lives since then. So I'm looking forward to having an updated discussion with you.
Yeah, I feel like I see you everywhere, which I always see as such a pro, especially when people are advocating for better women's health. I'm like, the more I can see and amplify their message, the happier I am. I will say, like, we've co-treated so many patients at this point in time. We actually are local to each other, or my clinic is local to your clinic. And whenever I meet someone who has met you, we all say the nicest thing. We all say the nicest things, and we all say that you're so nice. Like, this is like what people lead with. I'm like, oh, you got to see Dr. Leonardi. And they're like, yes, he's so nice.
Oh, that's very kind and nice to hear. In
I've,
this space, like being nice is what such an easy thing to do. Just be kind, be a nice person. Not that hard.
well, and it's funny because I think, especially when we talk about endometriosis, that patient experience that they've lived 1,000 lives before they meet you. And to walk into your office and have someone who is interested, curious, has dedicated their life to the advancement and research and pursuit of better access to care for people who are suffering from endometriosis. There's nothing more refreshing than walking into your world with your interest and attitude around this condition that has been really sort of shoved aside in the world of gynecology for so long. So I think I speak for all people that have endometriosis to say, like, how grateful I am for your work and how grateful they are for your work.
One of the reasons why I am so loud and like just try to be in as many places as possible is there's not enough people talking about it and there's not enough noise. And this is such a common issue. Endometriosis is so common. And even outside of endometriosis, the sort of sidecars around endometriosis are so common. And if we don't talk about it, nothing's ever going to get better. Noise is necessary. So I'm doing a lot of that because more of us need to know about this disease and the sidecars. And like that includes politicians and employers, and like everybody needs to know more.
Yeah, it's funny. My very first published article in my life was on endometriosis. And I remember when I wrote it, people were like, why did you pick that topic? Like, it was boring or unimportant or not interesting. And at that time, I was like, I think this is the maybe one of the most important topics we have in gynecology right now because of the morbidity, meaning the pain and the collateral damage that people with endometriosis experience. And yet it was something that was like very rarely talked about. And so I'm so grateful that you brought that level of noise to this topic. What I wanted us to focus on today. So if this is the first time that you are experiencing Mathew Leonardi, I totally want you to go back and listen to our previous episode that we did a couple of years ago, where we talked a lot about getting the right assessment for endo. You have been a huge advocate and one of the world innovators around ultrasound for endometriosis. Maybe for people who haven't heard that episode, like, can you just share the elevator pitch around why research into ultrasound for endo has been so pivotal for the disease in the last few years?
Yeah. The pitch, endometriosis was thought to be a disease that could only be diagnosed at surgery. And honestly, if you really ask the question, who wants to have surgery to get a diagnosis? The answer is probably nobody. Not surgery should not be a diagnostic test for anything. But there has been an evolution in the diagnostic imaging for endometriosis for many, many years, long before I entered into this space. So my work stands on the shoulder of giants that preceded me. And we can now diagnose most endometriosis non-invasively with ultrasound and with MRI. And that means people don't need surgery to diagnose this disease. You might use surgery as treatment of endometriosis, but it's not necessarily a diagnostic test. And it's a disease of a massive spectrum of complexity and which organs it affects and how it affects those organs. So the imaging can really give us a very clear mapping of what is happening. And that can then guide people's treatment decisions. It guides discussions of informed consent around treatment decisions, which for me allows me to give control back to patients over their own bodies when endometriosis has really taken a lot of control from them.
I love that you brought up the informed consent piece. Like to me, when I thought about all of the issues with surgery being the diagnostic technique, is one is it creates a huge bottleneck. So if we thought 1,000 people had endo, but we could only do surgery twice a week, we were never going to accurately depict the people that were suffering from endometriosis, and it leaves people untreated, unacknowledged, right? They don't get in the pipeline of support because they never get flagged. It also really skewed the research for a long time because we really only considered people to have endo if we had cut them open to check to see if they had endo, which is a whole other issue. But from the informed consent perspective, like for patients, they would go in not knowing if they had endo and come out having some of it removed. And the discussion around ovarian sparing and fertility sparing techniques and what was possible in surgery was not a discussion that got to be had prior to going into the surgery, and that created this huge loss of control for people, especially if they were hoping for future families and if ovulation was something that we wanted to try and preserve. So when this world for me got opened up, I was like, okay, we are solving two major problems here. One is we don't even have a clue how many people have endo. But also, when we're finding it, we're also putting people into a treatment process that they have not able to have a discussion about a lot of the time.
Mm. It's horrendous, actually, what has happened, and honestly, what is still happening in many places, including within our own province in North America. There are many people who are still having diagnostic surgery, and the surgeon is not prepared for what they're about to anticipate. Sometimes that preparation is over preparation. You think, oh my God, it's going to be so bad. The endo is going to be terrible. And based on symptoms or based on physical exam, and then you go in and there's two lesions. And not to say that those two lesions can't cause a lot of symptoms, but that's maybe you've booked too much operative time. You don't need to book the case for as long as you have. But the worst scenario is when surgeons go in expecting a little bit and there's a lot. And the organs that are affected are outside of their area of expertise. Endometriosis affects the bowel, it affects the bladder, it affects the ureters, it affects the nerves, it affects a whole lot of structures that gynecologists are not trained to handle surgically. And so what we see a couple of different things here. We see peek and shriek surgery. Surgeon goes in, oh my goodness, it's too bad, I can't deal with this. They actually leave, which is technically the right thing to do. The wrong thing to do is when surgeons think, oh, I'm going to do something because I feel like I have to do something. And it's like, I don't know, ego or heroics or whatever it is. They do a little bit, which then doesn't fully treat the patient and makes it harder for the endometriosis surgeon who is trained to do these more complex surgeries. It makes it harder for them to go back in the next time because now not only you have endo, you have surgical adhesions and you have disruption of the surgical planes, which makes that next surgery harder. So the lack of preparation has been terrible. And I mean, that's not even acknowledging that the person is kind of committing their body to a surgeon and not knowing what's going to happen and waking up to this news of what has just happened. That doesn't have to exist anymore. We have moved way beyond that.
Yeah, it's funny to even think that that still happens sometimes, right? That like these other options are available. And I would say you've done a brilliant job of educating even the clinicians in my world are much more attuned with the idea that we can use non-invasive imaging to assess for endo. But we have a little bit of a bottleneck there too, in terms of like trained physicians and sonographers, plus the site have the equipment that's necessary to do it. Like, how do things look right now in the landscape of getting assessed with imaging for endo, and where do we hope that goes like in the next couple of years?
I can speak to that on a local scale and then probably a little bit of a wider scale as well. So within our own province, uh, my experience teaching fellows has now allowed for an expansion of individuals with this particular skill set, where we call ourselves surgeon sonologists. So we're trained in minimally invasive surgery to handle the most complex gynecologic issues, including endometriosis, but we also scan. We either scan ourselves or we report ultrasound scanned by a sonographer. And I have trained a number of sonographers as well. So within Hamilton, we do this either at the house of McMaster University Medical Centre, or we do this at the house of SUGO, Specialized Ultrasound in Gynecology and Obstetrics, which is a community ultrasound practice. It's OHIP covered services. And with a referral from a primary care provider or a physician, like a gynecologist, was a Ontario billing number, the scan is covered by OHIP. And we're doing scans for endometriosis every day now. And these are scans that are done by our sonographers who are exceptional, and they're reported by myself or my former fellows who are now my colleagues. And we report on endometriosis ultrasound every day. But we do these very special days as well. We kind of colloquially call them endo days at Sugo, where almost every patient is booked in for an endometriosis ultrasound. And we've scanned over 50 people on a single day. And we do this at least once every 2 weeks or so. So I believe we are now reaching a point where we're actually caring for like a tremendous number of people. We're scanning patients referred from everyone across the province. And then those patients are going back into their communities, some of which are local to us still in Hamilton, and they can get triaged appropriately. So, for example, a patient who has severe endometriosis diagnosed on a SUGO scan can be referred to an endometriosis surgeon in their region, or if they're not available, to a region closest to where they are. And that helps that triaging process. So those surgeons are dealing with the patients they need to deal with. The patients who have maybe superficial endometriosis, mild endometriosis, no endometriosis on ultrasound, maybe those patients are more appropriately triaged initially to a general OBGYN to help with some of the management strategies that doesn't require the same surgical level as bowel endometriosis, for example. So I think what we're doing not only is diagnosing people, is we're also trying to enhance the triaging model of our province, our efficiency of care, so that people can get to the right person faster.
It's such a different conversation than we even had like however many years ago that was, maybe 5 at this point. Where the bottleneck was so much earlier in the situation, right? That people had to be referred to your specialized center to even start that process. But now there's, you're making a dent, like, right? We'll put it that way. You're making a dent in the number of
Yeah.
people that are waiting to be assessed or that need help to get that, like, which path do they need to walk down now? Because so many, primary care practitioners, it's not really within their scope or their job to make some of those decisions. But then even gynecologists that don't specialize in endometriosis maybe also don't feel comfortable making some of those decisions. So how wonderful is it for you to quarterback part of that, strategy for them, so then at least they can go back to their primary person, whoever that is, to be well supported. I just think that's so brilliant.
Yeah, thank you. I appreciate that. And it has been part of the master plan to be able to help more people in the province. Look, as a surgeon who deals with the most complex endometriosis, these surgeries are hours long. And we're in a somewhat limited health system, though for what it's worth, Hamilton Health Sciences has actually increased our department's operating time. So that's been a great asset. But nonetheless, we're still limited. So if if I want to try and help as many endometriosis patients as possible, I can do that by operating and managing my patients, but that's a fixed and small number. This opportunity can help dozens more. And there are fantastic endometriosis surgeons across the province that can be that surgeon, can deliver the medical therapies, the complementary and alternative advice and surgery, but guided by the expert imaging that we can provide, which is still a rare service. Though we run courses, I've run 4 courses now in Ontario, and we're starting to see a lot of the OBGYNs from Ontario, some of those who are endometriosis trained, come to do the course. And they're really keen to take the ultrasound probe into their own hand. And I'd say that's kind of like my biggest long con for my career is I want every gynecologist to scan because when the probe is in your hand, it's the most powerful tool as a surgeon. And so if we can start to train more minimally invasive gynecologic surgeons across the province, that'll help me a little bit because there'll be a little bit less demand and, maybe I can rest a little bit more, but, it'll make it more accessible for patients all over.
That's amazing. Yeah, you can I won't say that you'll be like sitting on the beach sipping some fancy drink while everybody else is doing all the surgeries, but maybe you could have a day off every once in a while.
Maybe, or maybe I'll be on the beach with my phone in the other hand, responding to research emails and,
That's
doing,
right.
yeah, we're not very good at resting. I don't think we are, Jordan.
Let's talk through some of those treatment options. So, like the categories or classifications in terms of treatment options that are available for people right now with endometriosis. Because I think, if when people have suffered for a long time with their condition before they get to even walk through the door and talk to someone, they often have an idea about what to expect as far as solutions go. And I will say that I find, patients with endo, it feels like by the time they cross that finish line to actually get support, it's really hard to meet their goals and expectations because they've had years and years and years of suffering. The moment they understand why we choose an option we do or what those available options are and when we decide to do one and not the other, they feel so much better about the solutions that are available to them. Can we just talk through those sort of buckets of what's possible when someone finally does get a diagnosis with endo?
Yeah, absolutely. Um, let's label the buckets, but then I want to take one step back before then diving into the buckets. So the buckets in medicine are kind of actually the same across most health issues. We have medical management, or we have, the classic pills or injectables, things that are medications delivered to you in a systemic way. Then there is surgery. And sort of, we've already alluded a little bit to surgery for endometriosis actually can be quite an array of considerations and options. Then there's the box of complementary and alternative management strategies, which for me is probably the biggest clutch box because this is a big box with lots of tools. These are sustainable, holistic, relatively side effect free options. And truly, endometriosis is a disease beyond the gynecologic system. It's a full body disease, and therefore we have to take this holistic approach. So those are the 3 boxes: medications, surgery, and CAMS, as we say for short in medicine. But before we kind of dive into how do you decide which one to do or how many to do, we have to take a step back and remember that each person walking through the door is a different person. We must take an individualized approach. So I don't follow a ladder approach where a patient must start with the combined oral contraceptive pill, and then if they fail that, they move on to the progesterone only pill. This is too algorithmic. It forgets that we have humans, individuals with different lives sitting in front of us. And those different lives can look like, a 22-year-old who's in university versus a 29-year-old who's actively seeking a pregnancy, or a 45-year-old who is, approaching perimenopause. Very different in life moments, very different in preferences. But then, even more granularly, we have to remember that endometriosis doesn't exist in a silo. So a lot of patients with endometriosis have other gynecologic issues, such as adenomyosis, polycystic ovarian syndrome, fibroids, polyps, hemorrhagic cysts. They have issues of the vulva, for example, like vulvodynia. These gynecologic issues all impact on the treatment decisions that a person with endometriosis has to make. And then, even wider, that box of other comorbidities extends to the gastrointestinal system, to the genitourinary system, the bladder system, to the myofascial system, that's the muscles and the joints and the bones, to the nervous system. And so, again, every element of that person is relevant to the treatment decisions. And that's why I call the approach the buffet approach. I say, think of a buffet. You have a million options in front of you. And you, as an individual, are probably not going to want or choose the same things that your friend or your mother or the stranger who's at the restaurant with you are going to choose. You got to take an individualized approach. And it's heavily driven by imaging in terms of the gynecologic diseases, determining what's in that person's body, but it's also heavily driven by the conversation, knowing that person's history, their physical exam, their journey, and understanding how to put all that together in let's discuss which strategies you will choose. So it's really complicated. And I don't know, I think when you understand that endometriosis is not such a binary disease, it's really complicated. It might provide a little bit of comfort or insight into why the treatments are so complicated and why the lack of success in simplified treatments, such as here's the pill, that's not going to work for most people. So that context, I think, might help patients understand the complexities, but hopefully it also helps all of the healthcare providers that are listening, those that are in the allied healthcare professional space and also the sort of traditional Western space. We have made this too simple. It's not simple at all.
I'm so glad that you brought that up because I think, in those three examples that you gave, right, we've got our young university person, we've got our person in the middle of a fertility journey, and then we have someone whose hormones are changing, and now they're going to experience the consequences of that, or like what comes next for them as far as that goes. They may actually all choose the same option, right? And they all may choose something different. And I think it's so helpful because, especially in the allied health space, we sometimes can poo-poo a particular option, forgetting that this person, like we're talking about a person who has to go and live their life, right, at the same time as trying to manage their disease. And whenever I've come up against allied health practitioners that are like, oh, none of my patients with endo use medication. And I'm like, well, you must not work with people who have very much pain, because at some point, someone is going to require medication. And if you've never worked with someone who's needed medication to control their symptoms, you are not seeing the full spectrum of this disease, actually, because that would be impossible for you to go through your whole career with someone who's never needed to take progestin-only medication so that they can go to work. So I'm glad that you brought that up, because it also, can give patients some of that context for why we have so many questions for them, and B, why they're maybe not going to get the recommendation that their friend did or that they read about in a blog, because their priorities are going to be different than that person. Our goals are different. Our short and long-term outcomes we're trying to figure out are going to be different than the person who's even beside them in the waiting room.
Yeah. And what we see, patients will walk in, we have intake forms, and one of the first questions is, what are your goals? What are your treatment goals here? And some people will kind of, again, simplify it, I want everything out, or I want to be pain-free. It's really simplified. These are desirable, outcomes, but what you hear online, what you read in a blog, what you see on an Instagram reel is not you, is not your story. That's why you need an expert to break down your story. If you don't have that expert to help kind of break down what your story is, from when it all began to how it's evolved to what other things are happening in your body at this moment, what are your preferences, what are your goals for fertility or not, all of this imparts an impact on that advice, on that decision-making process. And so hopefully people will appreciate that And I think most people know that they are an individual and they want an individualized approach. But at the same time, what has been offered to somebody else might not be the right thing for you, and vice versa. I hear lots of people have had side effects with this, that, or the other, but you're not them. You're not that person. So maybe that thing that your best friend didn't like will be actually perfect for you.
I always say nobody gets on TripAdvisor to talk about their mediocre chicken, right? Like we only hear about the food poisoning. And so it's so common, especially in the endo world, when I'm very pro internet forums and I had this conversation on another podcast and people were like, well, what about internet forums? And I was like, well, I actually worked in the PMDD space before it was a recognized diagnosis. And you know what? Facebook forums probably saved some women's lives because they were seen, they were heard, they found paths for support. And so I am very in favor of that, like, that group discussion around what's supporting people. The challenge with that is that sometimes the loudest message about different medication options or what have you just has to be taken with a grain of salt, because people will write that they hate their, Vyzan or Danagest. And then like when we look at it from a research perspective, it's, one of these great options for people. So you have to take that, the negative reviews online with a grain of salt for sure.
Yeah, I know. That requires building a rapport with the patient, them knowing that you're on their side. And I think one of the reasons why I have been successful or sought after as a gynecologist in this space is I believe people. I will take the time to try and make sure that you have your questions answered. The appointments are never rushed. This is also why we can't see that many people, and this is why the wait times are so long. But that rapport that you build will allow for misconceptions to be dispelled. It allows for the expectations of a patient to meet the reality of where those expectations can be. That again, that patient who writes, I want to be pain-free. I wish that I could help you achieve that. The likelihood is we're not going to get to pain-free, but we're going to get to hopefully less pain and better quality of life. If you don't take the time to explain things to patients, if you don't take the time to make sure that they know that you are trustworthy and you're on their side, and you don't align the expectations and reality, what happens is disappointment. And then you move on to a different provider and you get failed again and again and again. So yeah, we need to really try and spend time with people so that they actually know as much information as possible and they can make the right decisions for themselves.
I don't know if this is you or not, but if you're a naturopathic doctor or an integrative practitioner who prides yourself on being evidence-based, but don't have time to stay up to date with the research yourself, I have a solution for you. I'd love to invite you to explore and join the Confident Clinician, the only integrative medicine clinical decision-making tool that helps get research from PubMed into your practice with ease. We have built out exactly what you need to be the most efficient in your work, to be the best in your community, and to save you those precious hours that you're spending right now doing the research yourself. Joining with our premium membership gives you access to unlimited AI searches, gives you access to all of our previous database content, as well as our upcoming year of live delivered modules. You can check out more in the link in the show notes. I would love to see you inside of our community. We're making a huge difference in the way that practitioners practice integrative care and raising the bar for evidence-based integrative medicine. I hope you'll join us.
Are there any innovations in treatment coming down the pipeline? Like, I'm sure that surgical techniques have improved in the last decade, but I'm curious where things are going. Like, I haven't noticed massive innovation in the drug department, but I would love to know what your insider intel is on that front.
From a surgical standpoint, it's not the easiest space to innovate in. There's definitely some innovations in like devices in terms of our ability to be more precise. For example, robotic surgery is something that is not new anymore, but still relatively new on the ground in Canada. In Canada, we definitely have a slower uptake of innovation in surgical techniques and equipment because, of course, it's publicly funded and things need to be very well established before they're purchased by our publicly funded system. So robotic surgery definitely has growing space in endometriosis surgery. There's some interesting other techniques that we're seeing. For example, high intensity focused ultrasound for bowel endometriosis is something that's being studied and has just been approved in Europe as a treatment option for bowel endometriosis. Sclerotherapy, which is something that involves draining and burning the interior of an ovary when there's an endometrioma present. This was something that had a moment in time, then sort of left favor, and now we're starting to see dialogue arise again in sclerotherapy. So there's a few things. In the medicine space, one of the newer medications that is available now is called Myfembry in Canada, Ryeco in other places around the world. It's Relugolix. It's a gonadotropin-releasing antagonist medication. So it works at the level of the pituitary and potentially tells the pituitary to not stimulate the ovary to produce estrogen and progesterone. It does put people into a temporary state of menopause. It has a combined add-back hormone within it, so that way people are not completely deplete of estrogen for the purposes of protecting bones and cognitive health and heart health. And it's been now available in Canada for over a year, still anecdotally, because we haven't internally studied it, although of course there have been many published studies on it. We are seeing a lot of good responses amongst patients and a very low side effect profile, which is a strength for medications, because often one of the bigger issues is not whether it works for the symptoms, but what else is it going to cause as a side effect profile. But there's not a whole lot of other available medications at the moment that are new. And then in the box of CAMS, the complementary and alternative management strategies, we are doing a randomized control trial at MAC, looking at the Mediterranean diet in patients with endometriosis. And we are seeing more and more literature published in good high impact factor journals on dietary approaches. So that's fantastic, because we know that there's such an interplay between endometriosis and that gastrointestinal system. We're seeing the growth of pelvic floor physiotherapy. It's like the exponential growth of pelvic floor physiotherapy into patients with myofascial pain due to endometriosis. And we're seeing the growth of psychotherapy and psychology-driven approaches in patients with pain, and even patients without pain, because endo is not an easy disease to have. Even if it's more of a fertility issue that's arising, the psychological implications for that are huge. So we're building a lot of structured approaches to this, not yet in the OHIP covered health system, because as we all know, it's somewhat fractured, not quite universal healthcare system here in Canada, but we're seeing a lot of really cool innovations there as well.
When I think about like even my journey with working with patients with endo, that there were maybe a decade ago or longer, we had lots of thoughts about how to bring some of these treatments together. We had lots of thoughts about like baseline inflammatory status and like the overlap with IBS and the potential for their like that visceral hypersensitivity to be part of the pain experience of people monthly. There was a lot of creative prescribing when we used to use like Lupron, and then we'd kind of give them back some estrogen. So hopefully they don't like night sweat to death, but then worried that we were going to cause a lot of regrowth. And it's so fascinating to watch a condition over the period of multiple decades as we try and get like closer and closer to understanding, I'm going to say the truth in air quotes, because we do our best in science, but we're always in the like relentless pursuit of the truth. But it's so neat to watch us get like closer to understanding what it takes to pull together to have a comprehensive management strategy for people with endo. And I've always said I thought that the literature on endo has become more inclusive and compassionate over time. That like 15 years ago, it would be like, well, diet probably can't work, and this is the only drug. And now it's like, you know what? If it works, right? We are a little bit more interested in the patient experience. We're a little bit more interested in like the impact of psychology and chronic pain and stress and catastrophizing in this patient population. Like, I find it so interesting how the research has moved towards a more holistic look at this condition. What do you think?
It really, really has. And I look to organizations like the World Endometriosis Society, which is having its upcoming annual Congress in May in Sydney. And this meeting actually brings together people of different domains. We see allied healthcare professionals there. We see academic psychologists present, physiotherapists. We're seeing even patient representatives driving research. So it is a space that is becoming diverse in its academic contributions. And again, it reflects the complexity of this disease. There's a reason why we have failed women forever, is because it's been, here's the pill, here's Lupron. That's not enough. So we're very excited that we're starting to witness this true interdisciplinary approach, not just in that academic space, but clinically as well. So just here in our local community, and it's going to expand beyond very soon, we've developed Endometriosis 360. This is an interdisciplinary pain program for patients with endometriosis. It's developed by myself, Dr. Laura Katz, who's a pain psychologist, Jill Mueller, who's a pelvic floor physiotherapist, and Emily Optoff, who's a registered dietitian. And essentially, this program, it's a group program that helps people overcome many of those associated experiences that our traditional health system is just not, able to overcome with surgery or with medications. It provides people such a strong pain science education that they can understand what is happening in my body. Why is it happening? Why is my body responding in this way? And how can I actually evolve to not allow it to do that? The simplest way I love describing this program is it helps people regain control over their body that endometriosis has taken away, just due to its long-term inflammation burden, and then all of the associated years of invalidation and gaslighting and lack of good treatments. We have to undo all that. And it does require expertise, academic expertise, evidence-based approaches that are outside of our traditional health system. It's a very, very exciting time and space for holistic care for endometriosis.
Yeah, I think that's one of the things that I've always loved about talking with you about this condition, because, it's like so many physicians would become the absolute like world-renowned best in class surgeon and stop there. And to watch what you are undertaking for this condition, it's like it wasn't enough, hey, to be the like world-class renowned ultrasonographer and surgeon. No, you just had to like change the entire industry.
Well, and this program is brand new, but I can tell you based on some of the research studies that are happening right now, like the next evolution of things is coming as well. And as you mentioned, we're always in the pursuit of science and of the truth. I have these very realistic conversations with patients some days where I remind them that they live now. They are having care in a geographical, like they're in Ontario, their care is happening now. And I remind them that 50 years ago, that looked very different. And I mean, you definitely did not want to be a gynecology patient 50 years ago. But also, when we fast forward 50 years to the end of our careers, it's going to look very different. Really, it will look, again, very different. And we can't change when we live. So there's a little bit of a reality check in some of these statements. Like, we have to accept what we have now, but that doesn't mean that we're not in pursuit of more. And I am always thinking, where are we going? What's next? Where are the deficiencies? And I learn a lot of those deficiencies from my real life clinical experiences from my patients that tell me what works and what doesn't work and where those gaps are.
I appreciate your time so much and you sharing your work and wisdom with our audience. How can they find you, get connected, learn more, and maybe dip their toe into some of your other programs and work that you have on the go?
So social media, of course, there's a few platforms there. Instagram, Dr. Mathew Leonardi, YouTube, Mathew Leonardi, MD, PhD. I put out a lot of content there that sometimes might be seen as a bit high level for a lay group, but you know what? Endometriosis patients, you are very smart. And the more you learn about endometriosis at that high level, the better you're going to be. So don't let that sort of webinar focus, healthcare perspective deter you. LinkedIn is another place that is sort of become my new Twitter, which still exists in the background, but not so active there. And then clinically, so Sugo is a accessible ultrasound clinic, though obviously by talking about it, maybe there'll be a bump in referrals, maybe the wait times will increase. There already are wait times. That's still an unfortunate reality. But certainly if you want your primary care provider or your gynecologist to send you for a scan, sugoclinic.com, you can get the requisition, or any requisition can be used for a referral to any ultrasound clinic. And then my practice at McMaster, of course, still exists, though we are, due to demand, trying very hard to focus on those who are in our local health integrated network, the sort of Hamilton and surrounding area. So unfortunately, we can't take care of everyone in the province, but hopefully with Sugo as a sort of sidekick location, we can provide a little bit more care that way.
Amazing. And we'll put the links to all of those places in the show notes, so you can click right from the podcast description. Thank you so much for spending time with me, Mathew. I just appreciate you so much. You're so well-spoken, so passionate. Thank you so much for your time.
Thanks again for having me, Jordan, and thanks to everyone who's listened.
That's it for today's episode of the Real Integrative Medicine podcast. I hope you're feeling inspired, informed, and ready to make changes that truly support your health. If you found value in today's discussion, don't forget to hit subscribe, share this episode with someone who needs it, and leave a review. It helps us reach even more listeners just like you. Your health journey is personal and it's powerful. Let's keep building on the knowledge to give you the confidence you need to thrive. It's important to remember that the Real Integrative Medicine podcast is for educational purposes only. Be sure to talk to your doctor before making any personal health changes. This podcast isn't intended to diagnose you, and no doctor-patient relationship was formed by listening. We'll see you next week.